A middle-aged male patient of average height and build is lying comfortable on the bed, having a pulse rate of 90 beats per minute. It is regular of high volume and collapsing in character. The blood pressure is 160 by 60 mm of mercury with high systolic, low diastolic and a wide pulse pressure. There are visible carotid pulsations in the neck. The JVP is not raised. There is no cyanosis, clubbing and pedal edema. On examination of the pericardium, there is a visible cardiac impulse at the apical area. There is no scar, bulging or deformity. The apex beat is displaced in the sixth intercostal space at the anterior axillary line. It is thrusting in character. A diastolic thrill is present at the left lower sternal edge with the patient sitting forward. On auscultation, the first heart sound and second heart sound is normal. There is presence of a high-pitched early diastolic blowing murmur at the left lower sternal area which becomes loudest during the expiration with the patient sitting forward. There is also presence of an ejection systolic murmur at the aortic area and a mid-diastolic rumbling murmur at the apical area without preceding opening snap. The lung fields are clear to auscultation. There are no signs of the pulmonary hypertension. The diagnosis is aortic insufficiency or aortic regurgitation. There are no stigmata of the infective endocarditis and Marfan syndrome. There is absence of the Argyll-Robertson pupil for syphilis and absence of the ejection systolic click for bicuspid aortic wall and absence of the obvious features of the orthopathy for ankylosing spondylitis and rheumatoid arthritis suggest that the underlying cause of the aortic insufficiency is rheumatic in origin. A middle-aged male patient of average height and build is lying listening on the bed, having a pulse rate of 92 beats per minute. It is regular of high volume and collapsing in character. The blood pressure is 160 by 60 mm of mercury with high systolic, low diastolic and a wide pulse pressure. The JVP is not raised. There is no cyanosis, clubbing and pedal edema. On examination of the pericardium, there is a visible impulse at the apical area. There is no scar, bulging or deformity. The apex beat is displaced in the sixth intercostal space at the anterior axillary line. It is thrusting in character. There are no other heaves and thrills palpable. On auscultation, the first heart sound and second heart sound is normal. There is a harsh ejection systolic murmur at the aortic area which becomes loudest during the expiration and it radiates towards the right side of the neck. There is also presence of early diastolic murmur at the left lower sternal edge, heard based in expiration with the patient sitting forward. There are presence of the bilateral pedal crepitation in the lung fields. There are no signs of the pulmonary hypertension. There is no stigmata of the infective endocarditis. The diagnosis is mixed aortic valve disease. The high volume pulse with collapsing character, wide pulse pressure and displaced thrusting apex beat suggests that the predominant lesion is aortic insufficiency or aortic regurgitation, which will be further confirmed by the echocardiography.